So my name is David Monks. I'm an obstetric anesthesiologist, so I feel a little bit out of my comfort zone here, but I do have two psychiatrist brothers, if that helps. I don't know whether it does. I don't know. With kids. And I am currently at WashU and have an interest in interventions to treat and prevent postpartum depression. And I'll have a little confession and humble beginnings of my own particular journey with investigating ketamine. So the data from my own personal data is less interesting than maybe the other part of the presentation, which is to present the evidence that does exist and sort of sets up where my journey begins, really. And that, luckily, it's not the main reason I'm here, but I'll explain that in just a second. So as far as I'm concerned, I'm from around London, from Kent, and I trained in the UK and most recently was a consultant at St Thomas's. But in 2017, I swapped the Thames for the Mississippi, which is where St Louis is, or between the Mississippi and Missouri, if you like. But that's a picture of the arch on the Mississippi there. And if you don't know, St Louis is a moderately sized city in the Midwest, the US, which is placed in a geographical location that was quite important in the history of Native American history and also more recent immigration, but was probably at its height when shipping was the lot more central role in transporting goods and people, when it was one of the most populous cities in North America. I'm currently at Barnes-Jewish, which is the main hospital part of Washington University. And the reason I originally went was to study actually oxytocin pharmacokinetics and its adverse effects, one of those being potentially mood. And I very quickly saw that as something I was quite interested in and looking at other interventions, as well as ketamine. And our department actually has played a role in the history of not only ketamine as an anesthetic, but also as an antidepressant. So C.R. Stephen was our first chair, and he is seen as one of the pioneers of ketamine use as an anesthetic. This is his paper from the early 70s, when I'm sure he didn't expect that two of those three drugs would be nicked by psychiatrists and repurposed as antidepressants. But he's probably safe in the knowledge that the third won't be, being a muscle relaxant. That comes to the main reason I'm here, which is why I've infiltrated this conference, and that's to deliver the message from anaesthetists to stop stealing our drugs. Quite simply, it's just not fair. But at least if you're going to take them off us, would you treat them a bit more kindly and maybe stop using the word dirty? It's a very nice drug. It's very useful, saves a lot of lives across the world, especially in more poorly resourced parts of the world, in sub-Saharan Africa, where I have an experience of using it. And joking aside, we've got quite a friendly association with our psychiatrists in WashU, and we've just started up Pioneering Centre of Perioperative Mental Health, which collaboration between anesthesiology and psychiatry is first of its kind, so say funding from the NIMH and led by our current chair, Michael Avedon, and Eric Lindsay from psychiatry, with whom they've previously collaborated on a study of a 96-hour infusion of ketamine. So there's the setup, and that's why I'm interested in it, and that's why I'm in a good place to be doing it. So here's the pocket pilot study, which is just a pilot study, and it was just 23 patients, and I'll explain how we got to that. A little bit of background: postpartum depression, as I'm sure you know, is very common. It's one of the commonest medical complications of pregnancy. Up to about 1 in 5 of pregnancies can be affected by depression in one way or another. And it's persistent and not only devastating for the individuals, but also presents quite a substantial financial burden to society, which has been estimated as much as 2.8 billion per year in the US. So a pretty dramatic financial burden. Probably due to this background, is due to its success in TRD, but also due to our familiarity with the drug. Obstetric anaesthetists have been quite interested in its use for postpartum depression. And so there's been a flurry of studies in the last 5 years, or 5 to 10 years, looking at ketamine to prevent postpartum depression. That's why in the original slide I had treatment in brackets, it's because all of the evidence comes from prevention. I think that's more to do with anesthesiologist domain, which is the perioperative care, rather than to do where it's probably most useful, or hopefully will be most useful. So luckily for me, recently there was a meta-analysis published just earlier this year, which covered most of the data. Now, the meta-analysis is from Chinese university, and all 10 studies are from Chinese universities, which is worth noting. So it's a limit to the generalizability of the data for sure. They're some of them large studies or moderately sized studies, but some of them quite small. And 6 of them, probably the earlier ones, were looking at bolus administration. Now, 2 of those looked at 0.25 milligrams per kilogram, and 2 of those as 0.5 milligrams per kilogram. Again, part of this is because this is not unfamiliar territory for anaesthetists. We're commonly giving ketamine, or commonly giving drugs intraoperatively, obviously, but ketamine for breakthrough pain, and it actually has an indication for its anti-shivering effect during cesarean. There were 4 intravenous infusions over 2 days, so quite prolonged intravenous infusions, and they had a clever way of doing this. So they hijacked the PCA pump. So this isn't common elsewhere, but in China it appears that they have used sufentanil PCAs, which run as a background infusion of 2 mils an hour, which are over 50 hours usually would give the whole dose, but they can interrupt it with demands on the PCA. And they just added patient-controlled analgesia. So they have a button just like this one here, very similar to this, and they can give rescue doses, but they'll have a background infusion of sufentanil, which is a relatively potent, short-acting opiate. So they put their ketamine into these pumps. So they would be delivered over around 2 days. And I say that the rescue demands would interrupt that. So they would maybe shorten the infusion, but roughly sort of 40 to 50 hours. The first of these 4 included a bolus of 0.5 milligram per kilogram, these 4 studies that looked at this strategy. And then it followed with an infusion which works out at about 2 milligrams per kilogram, which works out as about 0.04 milligrams per kilogram per hour. So quite low doses in each hour, all under 0.1. So this one was 0.02 milligrams per kilogram per hour, 0.04 again milligrams per kilogram per hour, and 0.08 milligrams per kilogram per hour. But over 2 days, and with active metabolites, there may be consequences of that, and certainly as far as the dose is concerned. They found that in the first week, there was a reduced pooled postpartum depression score. There were various scores used, but one of the most common is the Edinburgh postpartum depression scale. And this is all studies, infusion and boluses. And they found a lower pooled prevalence of postpartum depression within that first week, and reasonably impressive effect sizes, but not persisting into 4 weeks, which is probably not surprising to this audience. No adverse effects other than more frequent vomiting with ketamine. Again, maybe not unsurprising to you guys. And on subgroup analysis, it appeared if you were going to give a bolus, 0.5 milligram per kilogram was necessary rather than the 0.25. And from their meta-regression, it appeared that prolonged infusion was more superior to bolus administration. The one study which has been published since then is a quite large study, 375 patients. Again, the same prolonged infusion, hijacking this patient-controlled analgesic pump of sufentanil, and it is even a lower dose. So we're now talking 0.01 milligram per kilogram per hour over those 2 days. And it, again, is quite impressive results if you look at the rate of postpartum depression. A word of caution, when anaesthetists talk about postpartum depression, they're talking about screening positive on a screening tool, or rather when these anaesthetists do. And so it's only a trigger to be referred to a psychiatrist, but still is a measure of depression that is commonly used. So we didn't have the benefit of most of this data, almost all of this data actually, in 2019 when we were finalizing our design. But it did appear that the prolonged infusion was going to be more successful than the bolus from what we could see. But it's certainly not very convenient. Most maternity units that I know of or have worked in Europe, in North America, and even in Australasia would be trying to remove all sort of obstacles to mobility, and that includes IV cannulas as well as urinary catheters. And so they'll usually remove them within 24 hours. So you can imagine a two-day attached to a pump whilst trying to look after a newborn baby in a low-risk population that might not be most to benefit is maybe not practically useful. So we wanted to look for a more convenient administration strategy and one that might reproduce the benefit of the prolonged infusion. So we wanted to focus on a subcutaneous injection, but we decided for the purposes of the pilot to compare it with the 40-minute IV infusion that was more commonly used in TRD. And we were planning to do blood samples, or we took the blood samples. We were planning to do a pharmacokinetic analysis, at least to see if there was comparable absorption profiles or plasma levels. We were hoping the subcutaneous would show that it was maybe prolonged compared to the IV infusion to try and mimic a longer infusion. But the main objectives of this pilot were to assess the feasibility of a future RCT to look at that, but focusing on the subcutaneous injection. So again, a part of the background probably worth emphasizing, if you are to see ketamine as a prodrug, is that there is dramatic differences in the relevant metabolism between non-pregnant and pregnant subjects. So I picked out 3 of the most relevant cytochrome P450 enzymes, and you can see it's as much as 20-fold or 10-fold or 5-fold differences in those enzymes. So this could have a profound effect on the time profile, certainly, of norketamine and the HNKs. Unfortunately, the blood samples we took weren't with metabolites in mind, and we're looking at the absorption profile of the subcutaneous ketamine, just looking at ketamine. And so we haven't performed that analysis, and unfortunately, it won't be relevant or unlikely unless they're at the upper end of those metabolic ranges and they're metabolized very fast. We're unlikely to see which is going to be the predominant metabolite amongst those in the time scale, which is 100 minutes post stopping the infusion. So we recruited healthy young ladies, English-speaking for the purposes of the pilot, who were scheduled for a cesarean delivery under neuraxial anesthesia. Again, quite a good, highly monitored environment to test this and to do the initial blood sampling and adverse effects monitoring. There were the two interventions, so 3 groups. So the IV infusion of 0.5 milligrams per kilogram of ketamine over 40 minutes, and then the subcutaneous injection of the same dose. And then each of those groups, the other route was saline, and then there was a group that got both routes for saline. And we used the Edinburgh Postpartum Depression Scale, as I mentioned, as our instrument. It's 10 questions, 1 specifically about suicidality, the rest about depressive symptoms, and scored on a scale of 0 to 3, so maximum of 30 points. And the most commonly employed thresholds are around 10 to 13 for referring to a psychiatrist, and we used 12. We measured anxiety on the GAD-7 and psychosocial risk factors, a baseline on the antenatal risk questionnaire. And as I say, our outcomes are mainly to do with feasibility. So we looked at the burden of disease in our population, the acceptability of our study procedures, and our ability to collect the data and the tolerability of the interventions. And again, we use that interoperative environment to get quite granular data on the adverse effects and vital signs, and also looked at pain. And post-operatively, the thing that we're most interested in as far as the RCT in the future was concerned was depression, anxiety, and plus surgical site pain on days 1 to 21 and 42. And we also looked at breastfeeding success, opiate consumption, and adverse effects. As I say, we ended up analyzing 23 patients. We recruited 25. One of them we failed to put the neuraxial in, so hands up, that's our fault. And the other one, the obstetricians failed to ask her whether she wanted a cephalic version for her breech presentation, which our spinal facilitated beautifully, but really ruined our chances of doing the study. So that was a shame. But that ended up in 23 patients. So 8 in each of the ketamine groups and 7 in the placebo group. Any differences between baseline characteristics didn't reach statistical significance bar 1, but it's worth just on this slide noting that it's quite a high proportion of African American and uninsured women, which is quite representative of the urban St. Louis population, and probably very different to a Chinese population that any of these studies were done in. And although it doesn't reach statistical significance for comparison across the 3 groups, when we assessed for this preoperative screening for anxiety and depression and psychosocial stress, you can see that the placebo group appears to be more depressed and more anxious, and we'll see that in one of the later slides. And they certainly had a higher number of patients with a pre-existing diagnosis of anxiety disorder. So there's the depressive symptoms over time and over the time points, and you can see at baseline, the placebo group in red were more depressed than both of the ketamine groups in blue and green, so blue for the IV group and green for the subcutaneous group. And no, with the repeated measures, unsurprisingly, no difference was found between groups. And again, that imbalance would make me reluctant to comment much on any trends in anything. So there was no difference in the GAD-7 or the pain. Likewise, no difference in the prevalence of postpartum depression using that threshold of the 12 on the Edinburgh scale. Placebo did use more morphine, but it doesn't seem that was significant across the 3 groups. Breastfeeding success was generally low across groups, which maybe is representative of the high risk patients that we serve in St. Louis. The good news is well tolerated. Both interventions seemed to, there was no difference seen across. We measured not only the psychomimetic side effects, but also common side effects you might see during a cesarean. And shivering was the only one that had a significant difference and quite a profound difference, even this small sample. But that's something that we already know. But not actually using this administration strategy, or either of these administration strategies. So it's maybe something to look at in future studies. Again, none of the other side effects were statistically significant, and none of the hemodynamic differences, or no hemodynamic differences were observed, although again, it was small sample size. So as far as our feasibility milestones were concerned, we did see quite a high burden of disease in our population, so nearly 35%. Again, they screened positive with an EPDS of greater than 12 for depressive symptoms in at least 1 postpartum assessment in that first 6 weeks. It was quite a low, that probably represents the burden of disease in our population, but also maybe an attractiveness to our interventions, the potential benefit in our intervention, which probably explains why approaching all comers and low-risk patients that are only 20% consented to participate. Not many women are keen to take an extra drug that they don't see is going to benefit them when they potentially could be passed on to their baby or affect their experience of their delivery. We've got a full data set in not as many as we would like, but we've learned some lessons about how to collect outpatient data in particular in these patients. And as far as future directions are concerned, this was just a pilot, and we're planning a future pilot on the basis of this, using our data on the subcutaneous route for ketamine, but trying to bolster up the intervention. So we're planning on doing 2 doses of subcutaneous ketamine, 24 hours separated. Again, for the purpose of the pilot, we're going to do it in cesarean delivery. So we're going to do it on day 1 and day 2 post-cesarean. And we're going to incorporate a course of interpersonal therapy with that to try and build a synergistic intervention that hopefully will have greater potency. And we're planning on targeting sleep and sleep deficiency as our mechanistic target for improving postpartum mood. As you probably know, there's a bidirectional relationship between sleep deficiency and postpartum depression. But there's also a good bit of data about sleep, a slow wave activity deficiency as a predictor of response for ketamine. So we hope to, by using some home sleep EEG monitors that we have, and one of my colleagues has got a lot of experience using, trying to capture peripartum sleep. So hopefully in third trimester, a couple of nights, and then in the postpartum nights, and then following, and see how we engage with that target, and if that influences our effect on mood. And I won't go all the way through that, but that's the rough schedule for our. It gives me a headache looking at it. Rough schedule for this trial that we're planning. And it's a clever way of doing the pilot where we're looking at both scheduled and unscheduled cesareans, so we don't miss out on too many patients, hoping to increase our recruitment rates, but also allow us to pivot to whichever group or both might benefit from it most. So with that, I'll say thank you and ask for any questions.
Thank you, David. Any questions, please?
Any issues or thoughts, concerns with ketamine and either breastfeeding or immediately postpartum related issues, but specifically breastfeeding? Is that contraindication? Are you telling them pump and dump? How are you approaching that issue?
So it's a limitation of our studies. We didn't look very. We just looked at success, so it's a very crude measure of it. But there was data that suggests that doses as much. So there is some preprint data. It's not peer reviewed, but from 1 milligram per kilogram IM, which has shown not to get into the breast milk to any clinically significant extent, which is extremely encouraging, considering that's a much bigger dose, double, and its absorption profile will be much quicker than the subcutaneous. It's likely to be theoretically.
Is there a particular theoretical rationale for interpersonal therapy? Is it just because it's indicated for that population, or are you expecting some sort of specific synergy rather than additive effect with the ketamine?
So it's more to do with the fact that my collaborator is an expert in IPT and has published in using it in postpartum depression. And when we were looking again, we're looking for future funding, trying to look to bolster up this intervention, because on its own, a single dose of subcutaneous ketamine maybe needs a bit more buy-in, maybe not so much from this audience, but maybe from other funders, in order to convince them that it will be effective. And as I say, Shannon Lindsay, actually wife of Eric Lindsay, is an expert in delivering IPT. So that was where that came from. It's part of the fruit of that collaboration.
I guess I was wondering about the target population for this, because obviously, like you say, it's not going to be massively attractive giving a pharmacological agent to a woman just giving birth if she doesn't think the risk's high. And so, but there's gradings, I guess, of risk of this population. And so from the sort of psychiatric point of view, I guess the folk that I worry about the most are people with bipolar disorder, particularly beforehand, because they have a very, very high risk of an episode in the immediately postpartum. And you often have to discuss, the pros and the cons of medication during pregnancy and that sort of stuff. And it's a kind of difficult conversation. And if there was something like this that was evidence-based for those folk that, have, 80% likely to get events or whatever in the postpartum period, then that might be particularly attractive to that group of folk.
Yeah, and that's our plan. Our plan isn't to do low risk, it's to look at a higher risk population. We certainly found anecdotally a lot of engagement from women who'd had previous psychiatric diagnoses or previous experience of postpartum mood disorder. And so we are looking to certainly look for, going to screen patients on the EPDS, and only we're going to look at a screening threshold of 10 to what we picked. So mildly depressed, to look as partly because we think it will enrich the population, hopefully benefit them more, and they are patients who are more likely to be on antidepressants and maybe looking for some kind of effective intervention.
Right.
Just a technical question, Laurie Calabrese. Were you administering ketamine at the start of anesthesia or after the baby was out?
No, after baby was out. So it was, yeah, and it was shortly after delivery. but it was designed that we could give it and have that monitored 40 minutes, certainly while the IV infusion was going, while they're in the operating room. But there's no reason for it to be there other than it was convenient for, one, it's our domain, so it's easier for us to do the research, and two, it's a great place to pilot and look for tolerability. So we had quite granular data from that.
I had it in my mind that there was a Chinese study that looked at the preventative aspects and found an effect 6 months later. Have I just got that wrong, or I don't know. Okay, I'm just wondering if that particular trial study had particular characteristics.
Yeah. I don't know. No, I'm not aware of that data. That would certainly from this meta-analysis, and it was a recent one. And they found more studies than I'd found in my searches, even my recent searches for grant applications. But I didn't come across that. But that would that would be great news if it was. But they found that it wasn't at 4 weeks. They didn't find an effect across the trials.
Okay, well, David, thank you very much.
Thank you.
We'll go next.